Okay. All right. So let me now introduce to you Dr. Lee. She's a senior consultant and a medical oncologist at Icon Cancer Center, and she's also the program director for the Icon Young Women's Cancer Program. She specializes in breast and gynecological cancers, especially focusing on young women with breast cancer and research on that. To give you a little bit of bio on Dr. Lee, she graduated from NUS with, as you can see, Bachelor's of Medicine, Bachelor's of Surgery, and after obtaining a Bachelor's of Science in honors in Bachelor's of Science. My apologies. All right, so for her work in breast cancer, she was also awarded the International Fellowship, and she trained as a fellow at Dana-Farber Cancer Institute, focusing on young women with breast cancer and pregnancy-associated breast cancer. As mentioned earlier, she is the program director for Icon Young Women's Cancer Program, and she was actually involved in setting up this national program for young women with breast cancer to help raise awareness and education about it. Now I will pass on to Dr. Lee. I will stop sharing and let Dr. Lee share, and she will continue to talk.
Okay, let me just start sharing first.
Okay.
Can you see?
Yes.
Okay.
Yes.
Okay, thank you. So thank you for joining us again today for this lunch talk. 1 hour is quite long. I'm not going to talk non-stop for 1 hour. So maybe I will just give a short presentation and then we can share together and then talk about questions and answer. So this topic is really quite broad. But breast cancer, nothing you are unfamiliar with. Basically, I'm just going to focus on young women with breast cancer, fertility preservation. I think just now we mentioned a lot of interest here, as well as breast cancer during pregnancy. So I think the introduction has already been done. So basically, my interest is in women's cancer. So the scope I'm going to cover today, actually I tailored this talk without knowing the demographics. So I have included some background on like burden of breast cancer, symptom, risk factors, treatment modalities. I think we can all revise and see how we can try to reduce the risk factors of breast cancer. And then I will go into young women with breast cancer, fertility preservation, as well as breast cancer during pregnancy. I think we can make it quite informal. You can, if you have burning question, you can speak up, or we can discuss, or if not, we can just talk about it after my talk. So to start off, I think this graph is very familiar to all of you. Breast cancer in Singapore is definitely increasing. If we look at the age standardized incidence rate and we look at the pink line, this really is rising very sharply and is quite alarming. So the incidence of breast cancer is rising. I think looking at the numbers from 2011 to 2015, the number per year is about maybe 2,000 odd. But if we compare the two graphs, right, the first one on top basically talk about the incidence rate, but the one below talks about the mortality rate. If you look at the mortality rate, the good thing is that it's not rising at such an alarming rate. And we like to think that, it's due in part to breast screening, to awareness, to picking up cancer in the early stage. And we really have to credit, BCF with a lot of all this like cancer awareness. So when we talk about breast cancer, it's, a lot of people just think that it is cancer rising from the anterior part of the chest. They do not really know where exactly it's coming from. So if we look at the structure in detail, the breast is actually made up of a lot of structures like the muscle, the fat, the lobules, and then the ducts. So the most common cancer actually arise from the ducts of the breast, meaning the ducts that conveys milk from the lobules to the tip of the nipple. So this is termed invasive ductal carcinoma, and it accounts for roughly 70% of breast cancer. The other part of the breast that contributes to the second majority is the lobules. So the lobules accounts for about 30%, of the breast cancer, and we term it invasive lobular carcinoma. So what are the common symptoms? In fact, recently I've been on the Smarter Health on Facebook, and I get asked these questions very regularly. Like, when do you really seek help? So I think I just want to draw your attention to the common symptoms: breast lump in the armpit, changes in the shape, symmetry, skin changes, nipple retraction, nipple discharges, and even pain. So anything that is, new, that's out of the ordinary, that persists despite, 1 or 2 weeks, that doesn't go away, I think it's very important to seek medical advice. Then next, we come to risk factors. I think it's important to know what are the risk factors that we can really change. Mainly is lifestyle, diet, so that we can reduce the risk of breast cancer. There are, of course, non-modifiable risk factors that we can't do anything about. So what are the modifiable risk factors? I think the most important thing that could potentially account for the rising incidence rate of breast cancer is really, American lifestyle, American diet, obesity, sedentary lifestyle, and even alcohol consumption, smoking, and also taking hormones in the form of hormone replacement therapy or certain types of oral contraceptive pills. Of course, the non-modifiable risk factors we really can't do anything about. So those will include like being female, aging, like certain race, especially Ashkenazi Jews, so they are predisposed to getting breast cancer, and also family history of BRCA1 and 2 mutation. And then we have the group of like early menarche, late menopause, and delay or no childbearing, because they essentially expose the body to increased cycles of hormone cycling during the menses period. And for some people, if they require chest irradiation at a young age, this will subsequently predispose them to getting breast cancer at a later age. So what we really need to advocate is exercise. Try to quit smoking, keep a healthy weight, or at least, not drink or drink in moderation. So most of my patients will know me as, almost like their trainer, because every session I'll tell them they need to exercise, clock 150 minutes a week. I think I can't stress this enough. And we require, at least moderate intensity aerobic exercise. The other thing, of course, is breast cancer awareness, breast self-examination. You need to be aware of your breast to know it when, to pick up on the changes, to pick up on lumps or skin changes or discharges. And breast cancer screening, of course. So in Singapore, we have the screening guideline for women between 40 to 49. Discuss with your doctor. And if you go for screening, the mammogram must be done once a year. If you're above 50, then once every 2 years. And for younger women, if they have significant family or personal history, they may even need to be screened at an earlier age. And essentially, it involves a mammogram. So what is a mammogram? I think we are all familiar also. Basically, it's an X-ray picture of the breast, and the breast will be sandwiched between 2 plates for the X-ray to be taken. So a lot of people who are very fearful, they will, hear stories from others that, it's very painful, etc. But really, it is a very fast procedure, and generally there are some tips to, reducing the discomfort level. For instance, do not go for your mammogram, especially peri-period, before your period definitely, because it's more sensitive and tender. So when we find anything on the mammogram, for instance, if we find a lump, a suspicious lump, we need to do a definitive biopsy to sample the breast lump to confirm the diagnosis. And even this is usually done as an outpatient procedure. It's done usually under local anesthesia. So when we talk about treatment and diagnosis, we will need to stage the cancer. So for intent and purpose of this discussion, I will just dichotomize it into early stage versus late stage. So this picture really depicts a later stage, example stage 4, where it has spread to other parts of the body. While it is not curable, it is highly treatable in this day and age. And so we have the early stage 1 to 3, and this represent the curable stage of breast cancer. So when we talk about treatment, so the dichotomy is early versus late. And early stage, we will definitely have surgery, which is curative, which is definitive. And that encompasses the local therapy coupled with radiation, plus minus radiation, depending on whether you do mastectomy or whether you do white excision. And of course, we have the systemic therapy in the form of like chemotherapy, hormonal therapy, even like immuno or targeted therapy to reduce the risk of the cancer coming back. So for late stage, as I mentioned, is really very treatable and is mainly by systemic treatment. The local therapy is generally required for symptom control if there is pain locally or if there is bleeding, then the radiotherapy can help to address all these issues. So the treatment will also depend on the biology of the cancer. And when we talk about biology, we are talking about the grading, whether it's aggressive, whether it's indolent, and also, the receptor status, which can then pinpoint us towards what type of treatment the patient can receive. So essentially, for treatment consideration, we have to look at the stage of the cancer, the hormone receptor status, as well as the grade of the cancer. Then when do we give the treatment? So when we talk about systemic treatment for early stage cancer, it can be given before the surgery or after the surgery. For treatment given before the surgery, we'll term it neoadjuvant treatment, and those given after, we term it adjuvant. There are certain cancer subtypes that we will select for neoadjuvant treatment, and they are predominantly the more aggressive subtypes, such as HER2 positive or triple negative. And the rationale of the neoadjuvant treatment is to quickly shrink the cancer so that we can target the aggressive cancer as soon as possible, and it also helps to achieve breast conservation if that's what the patient desires and reduce the cancer recurrence at the same time. The rationale of the adjuvant systemic treatment is to reduce cancer recurrence. So when we talk about systemic treatment, it really depends on the biology and what are the type of the treatment that the patient needs. For instance, if it's a HER2 positive disease, then the targeted treatment will be required, and that will last for about a year. The systemic chemo part usually lasts for about 3 to 6 months and is given in a cyclical fashion. So the hormonal therapy is an oral pill that you take, especially if it's hormone receptor positive, and is taken for up to 10 years now, depending on the risk profile. And radiotherapy is given as soon as possible after the chemo and after the surgery. So now let's talk a bit about young women with breast cancer. Why is this topic important in Singapore? In the Asian population, we see that this number is actually much higher than our Western counterpart. And if I put it side by side, you can see, if we contrast the figure, in Asian population, age 44 years and below, 19% of breast cancer are diagnosed in this population. If we talk about the Western population, the number below 40 years of age is probably about 4 to 7% of the breast cancer population. So in Asia, I think this is an important problem. And of course, like me, I'm a practicing medical oncologist, and I do see a higher number of younger women. Like, for instance, I just saw a young lady, 30 years old, who is newly diagnosed after she just got married yesterday. So the general principle of treatment is actually the same, but because they are young, we really have to, group them as a group, unique group, and address that issue, which may be different from the older counterparts. So what are some of the psychosocial considerations? Basically, if they are very young, they may be at the peak of their career, or they may have young family, they have to juggle between work, young family, and then with a new diagnosis. And of course, they may get peer pressures because, if you look at your peers, then you will feel maybe especially upset, like, your peers are all healthy and young. Why is this happening to you? You may have all these questions. And also the treatment, as well as the disease itself, can cause issues with fertility, sexuality, as well as relationship issues subsequently. And for patients who need to take hormonal pills or ovarian suppression, they may have body image or self-image issues because the ovarian suppression and hormonal treatment can cause perhaps weight gain or even, dry hair, dry skin, things like that. The side effects are more pronounced in younger women. And then all this will in turn affect the adherence of the patient to the treatment and the compliance issues. Of course, the other big problem is hereditary disease that we have to consider for younger patients who are diagnosed. So like I mentioned just now, for hormonal treatment, ovarian suppression, younger women usually feel more side effects. It's not difficult to understand because, if you compare a lady who is like late 40s, 50s, they're approaching menopause, definitely the hormone level is lower. And then you compare that to a young lady, 30 years old, and if you suppress the hormonal drive for these two ladies, you can see comparatively the younger one with a higher drive initially, suddenly the hormonal drive is suppressed, they will experience more pronounced side effects. So these are some of the treatment-related issues. So how about the cancer? Are they any different? So usually the cancers in younger women tends to be larger. They may be more aggressive and they are generally diagnosed later. Why? Because they usually for younger women, they have lower index of suspicion. So when they find something, they will feel that it can't be cancer because they are still young. So usually when they are diagnosed, they are at a later stage. The treatment still depends on staging, still depends on biology, and it doesn't differ based on that, but it differs based on the size of the cancer at diagnosis. And because of that, neoadjuvant treatment tend to be more common because if the cancers are larger at diagnosis, then we want to rapidly shrink it down to try to achieve breast conservation. So I think after all this theoretical thing, maybe it's easier to put it into a perspective with a case study. So this lady, I've seen this lady like maybe a few years ago. So it's a true story. She was a young lady, 30 years old. When she saw me, she just got married a month before. And she was then diagnosed with a 4-centimeter breast cancer, ER positive, HER2 positive. Luckily for her, the lymph node was negative and she was worked up for chemotherapy. So, during a new diagnosis for a young lady, it will be very difficult for them to think about a future after diagnosis and treatment because for them now, they are faced with a diagnosis that is life-changing. So they may not be able to think out of the box. So that's where I think my role comes in. I think it's very important for me to remind them, you are going to have a life after the diagnosis and treatment. So you need to think about what you want 10 years down the road. So this lady, she hasn't completed a family. I sent her to see a gynae, and in fact, we managed to squeeze in the whole procedure of IVF, which is embryo cryopreservation, within 2 to 3 weeks. And she was started on neoadjuvant chemo-targeted treatment about 2 to 3 weeks later. At the same time, we also initiated genetic testing. So I will come back to this case later on, and we'll talk about fertility preservation. Why is it important? I think at the start of the talk, we did mention this is because, for early stage breast cancer now, there are more and more patients who are diagnosed early, surviving longer. So there's improved survival, which is a very good news. And hence, it's very important to ensure that these survivors have good quality of life, that they can pick up their lives from before diagnosis, they can look towards a fulfilling life of getting married and having kids, or rather just have the choice, right? Because a lot of us wants to have the choice. Younger survivors, they really have years ahead of them. So fertility issue in young women with breast cancer. The first thing to establish is whether their family planning is completed. So they will usually require a thorough assessment by gynecologist or obstetrician. And some of the common questions they tend to ask will be whether they can check their fertility level before treatment, how will age affect their fertility, and what are my chances of getting pregnant after treatment, and how can I try to preserve the fertility. So we come to Fertility 101. So women are born with a fixed number of eggs, and this number, they do decline through life, and the quality of the egg also decreases with increasing age. At about 50, which is the average age of menopause in Singapore, the ovaries will start releasing the eggs. So what is the likelihood of subfertility with chemotherapy? It really depends and boils down to a few factors, such as the type of the drugs given, the dose given, and the current age of the diagnosis of the mother, of the female, and what was the fertility level before the treatment. So it's very important, it's a decision that you have to make and discuss with your treating oncologist before starting the systemic treatment for breast cancer. So in Singapore, we have a few options. The tool that is in bold is actually the preferred method. So embryo cryopreservation is the gold standard. Oocyte cryopreservation is another method. So these two procedures actually, there is a short downtime of about 2 weeks to 3 weeks because it involves, almost like an IVF procedure where, you will need stimulation with hormone injection to get the eggs to be mature, and then eggs will need to be retrieved before the chemo is initiated. So for the embryo cryopreservation, essentially when the eggs are retrieved, they will need to be fused with the sperm, and then the resulting embryo will be stored. For the oocyte or the egg cryopreservation, it's just one step short of the embryo cryopreservation, meaning there's no fusion with the sperm. So the eggs are stored. And why is there a distinction? Is for a very practical reason, because by Singapore law, embryo cryopreservation can only be done for legally married couple. So the other methods includes ovarian tissue preservation and also ovarian suppression. And these two methods will feature more dominantly, especially if the disease is very aggressive. We really do not have 2 weeks to spare to try to start the chemo as soon as possible. So the ovarian tissue preservation is essentially really a 1 to 2 days downtime, because it's a surgical procedure whereby the ovary on the whole or the ovarian tissue is removed and then cryopreserved. And years later, if you want to try to get pregnant, this tissue will be implanted back in. And ovarian suppression essentially is just a jab to suppress the ovary. So it's an injection, hormone injection to suppress the ovary. It can be given like on the spot. And the rationale is to make the ovaries dormant so that they are protected from the effect of the chemotherapy. So these are the few methods that we commonly discuss with our patients. So lastly, I do want to talk a little bit about genetic counseling, also because when the patient is young, there's always a chance that they may have inherited BRCA1/2 mutation, which predispose them to breast and ovarian cancer syndrome. And they will need genetic counseling to decide on whether they want to do the test or not. And they usually have to go through pre-test counseling, post-test counseling. It's not a very short thing that they can do within like one setting, because they need to be counseled due to the implication of the test results. And also, if the result comes back positive, then there needs to be a discussion on risk reduction surgery, such as removal of the breast and ovaries. So this is just a cartoon illustration that you need to plan time aside for discussion of genetic testing. I think this is something I want to slot in. Is a bit more technical, but this result is fresh from ESCO 2021 June. So if you all know or follow ASCO, it's basically the biggest cancer conference and is held yearly, June in Chicago. So this year, none of the oncologists can go. So essentially it's held over the internet. So basically this result highlights that for high risk early breast cancer, and the BRCA1 and 2 positive patients who are triple negative or hormone receptor positive, when after they go through the routine treatment of surgery, radiation, and chemotherapy, when they are assigned to 1 year of this new treatment, which targets the BRCA1 and 2, called olaparib, they actually survive, have a better disease-free survival. So this result is actually practice-changing. So these are all fairly technical, but what I want to draw the attention to is that I think gradually, because this result is practice changing, we have to consider more BRCA1, 2 testing upfront, especially for patients if they are high risk. So next, coming back to the case. So what happened to the lady? So her genetic testing result came back. She happens to be positive for BRCA1, and at the surgery, she underwent double mastectomy, meaning it's prophylactic on the other side with immediate reconstruction. She also completed her adjuvant treatment, hormonal treatment, and 5 years later, after her diagnosis, she desired pregnancy and she reimplanted back her embryo and she successfully gave birth. So in essence, this is a positive story, which is true. And after her pregnancy and her delivery, we discussed with regards to risk reduction for ovarian cancer, which is removal of the ovaries. So that concludes the part on breast cancer, fertility. Just bear with me for a short 5 more minutes. I will just touch a little bit on treating breast cancer in pregnancy. This is a very challenging problem because imagine it's challenging for both, the oncologist as well as the gynecologist and definitely the patient. So when the patient is diagnosed with breast cancer when she's pregnant, there will be a lot of therapeutic ethical challenge because when we give treatment, the mother is the beneficiary of the treatment. We are giving chemotherapy to treat the mother. But because of that, we may put the fetus at risk. So it's very difficult to avoid some element of compromise. Hence, there's a therapeutic challenge here. So what happens is that we really need to individualize cancer care in pregnancy and involve the whole team. So usually we work very closely with our gynae colleagues, and then generally the fetus will need to be monitored, like even on a weekly or 2-weekly basis while we are giving chemotherapy. And when we give treatment, we have to consider risks to the fetus, such as from the treatment, chemotherapy, surgery, the short-term toxicities, as well as the long-term toxicities. And the risk to the mother, whether they can safely defer the treatment to after delivery or whether they need to start treatment as soon as possible to improve their outcome of their breast cancer. So all this will depend on a lot of factors. For instance, the disease type, the stage of diagnosis, the gestational age when the patient was diagnosed, as well as the patient's preference. So there are actually 3 broad methods that we can use. The first one will include deferring all the treatment to after delivery. But generally, this is only possible if the cancer is detected towards the end of pregnancy. Most of the time, the cancer is generally detected in the middle, like either the first trimester, second, or even the early part of the 3rd trimester. And if we are faced with this situation, then we have to decide on starting treatment as soon as possible. Lastly, the option, of course, of terminating pregnancy is there, but no data suggests that termination actually improves the survival for the patient. Hence, it's often offered to only select patients who are deemed to be very high risk or even stage 4 disease. So this is just a graphic and it summarizes, what can be done during breast cancer in pregnancy. So we can actually do quite a lot of things, like we can give chemotherapy from 2nd trimester onwards. We can do breast surgery all the way, including sentinel lymph node biopsy, which is done during the breast surgery. So these are the things that we can do during pregnancy. Others like endocrine therapy, anti-HER2 treatment, and radiotherapy are usually deferred to after delivery. So in short, I think I want to summarize that for young women, the cancer journey is a unique one, and we definitely have to provide support step by step, be it psychosocial, fertility, medical, and even financial issues needs to be targeted. So we generally talk to the patient, step one at diagnosis, avail to the different treatment options, and discuss fertility and genetic counseling in detail. So with that, I think I want to end my talk, and thank you. We can do some question and answer.
Yes, thank you very much, Dr. Lee. I will share my screen. Sorry, just give me a minute. I do have a list of questions actually for you. Okay, so sharing. Yes, can you see my screen?
Yes.
Yeah, okay, so you see Q&A, right?
Yeah.
Okay. All right. So we have a couple of questions that were asked during the, or rather when they registered for the talk, they asked certain questions. So I'll just ask you those questions first. I'll start off with those questions first. One of the questions was, how long must one recover after a mastectomy or cancer treatment before one can resume IVF?
Okay, then it really depends on the biology of your breast cancer. For instance, if you are hormone receptor positive, then it's advisable for you to take hormone pills. If you are triple negative, we know that the recurrence risk is the highest in the first maybe up to three years post treatment. So we generally advise, for anyone who wants to get pregnant, for them to wait at least, 2 to 3 years after the definitive surgery, followed by some hormonal treatment if they are hormone receptor positive, or even for triple negative, before considering getting pregnant.
Okay, thank you. We have another question which was actually asked just now by someone. Let me read it. All right. Okay. So someone who is basically in this talk right now, she asked this question. She said that she is taking Zoladex injection to protect her ovaries, and because she's still hoping to conceive her second child. So she's asking whether this is the best method, and also what is the earliest time that she can try to conceive again after she has completed her treatments. As well as, sorry, let me just read the last part as well as should she delay taking tamoxifen and decide to conceive first?
Okay, so I think this question is rather specific because it really depends on the biology of the breast cancer, as in we really need to look at her breast cancer risk. For instance, we need the full histopathology, and then I will be able to advise further. Generally, Zoladex, which is one of the methods that I mentioned just now, ovarian suppression, most of the trials so far suggest that it works better in triple negative breast cancer. Hence, it really depends on the subtype of your cancer. However, as I deferred to earlier, if we need to start early, depending on the biology of the cancer, if it's aggressive, and you do not have like 2 to 3 weeks before starting treatment to talk about IVF, then the next options will be either ovarian suppression or ovarian tissue cryopreservation. So these are the two other options. So I think she is doing the last option now. The chance of getting pregnant compared to embryo cryopreservation is definitely not as high, but that is still one method, So the second question is with regards to when, right? So I think I answered that earlier. It still depends on the biology, whether it's triple negative, whether it's hormone positive. If it's hormone positive, advisable to wait at least 2-3 years, at least take the hormone pills for up to 3 years before, before breaking to consider pregnancy. The same goes for triple negative, because the recurrence is the highest. It's actually a slope. It's actually a peak and then it tilts down. The peak is the highest within the, first 2 and 3 years. So we generally advise, getting through this peak before considering getting pregnant. What's the last question again? Sorry.
Whether she should delay taking tamoxifen and decide to conceive first.
So you should already be on tamoxifen, right? Because after surgery, it depends on the biology whether you need chemotherapy. So usually after surgery, you may be doing chemotherapy. After chemotherapy, you have to start your tamoxifen.
Okay.
So I think for this question is rather specific, and it potentially requires me to look at the pathology, histopath, and talk to the patient. So if she wants to talk to me, we can take it offline.
All right. Okay. Yeah, I think she would have heard that she's in this talk itself. Actually, regarding tamoxifen, there is another question that is pretty similar. I'm not too sure if you would say that it's also a special case, but basically one of the questions was that after treatment, her oncologist wanted her to take tamoxifen for 5 years, but she's asking if it's possible to skip it in the first year and try to conceive a baby first. Again, very similar question. And then after conceiving, take tamoxifen. She's also in this talk right now.
Yeah, so as what I mentioned, I think it's better to complete at least 2-3 years of endocrine therapy before stopping for pregnancy. But then it requires a lot of information. You see, it depends on what age is the patient now. I mean, whether she can actually wait the 2-3 years, and what is the ovarian reserve. So this really requires a very personal consult.
See, all right, thank you. The next question on my list is that if someone is still in remission for less than 5 years, would pregnancy increase the risk of relapse?
Okay, I think that's a good question. Basically, like now there are a lot of retrospective studies done on this question to try to answer it. So from all the retrospective study, it doesn't seem to indicate that getting pregnant after a breast cancer diagnosis will increase the chance of recurrence or getting a new cancer for now. Basically, conversely, there is a healthy mother effect. So it seems that patients who, after a diagnosis, could get pregnant and give birth, they tend to have a better outcome. But these are all done on retrospective analysis. What we want to look forward to is the result of a prospective study. The prospective study is termed positive trial. So this is a trial that is actively accruing. Basically, it studies prospectively patients who are diagnosed with breast cancer, who are on hormone treatment, and the trial accrue patients who are on hormone treatment and break them after 2 or 3 years of hormone treatment for them to get pregnant, and then follow these patients through in a prospective fashion to find out for this patient whether their breast cancer recurrence risk is increased. So this trial is still in progress, and we're waiting for the results.
I see. Okay. I have actually 2 more questions for you.
Sure.
One is, should stage 4 breast cancer survivors plan to conceive and start a family? That's actually one of the questions. Yeah, by the survivors.
So then it will depend on the burden of disease, the stage of the disease, as well as the biology of the disease, whether it's a very indolent type of disease, whether it is active, whether there's huge burden of disease, or this needs to be properly assessed before we can give a recommendation. Generally, for stage 4 cancer, meaning the cancer is not treated and not cured, that means there's still cancer in the body. Usually it depends on then whether it's endocrine sensitive, because if it's ER positive, PR positive, the pregnancy and the surge of hormone can potentially increase the risk of the disease progression.
Thank you. Just our last question would be, actually, because you mentioned about chemotherapy during pregnancy, one of the questions was, can I skip chemotherapy? Or rather, this is not about chemotherapy during pregnancy, but it's more for before pregnancy. Can I skip chemotherapy after my surgery to start having a child first?
I realize the questions are quite similar. So
Yeah.
again, I think we really need to know like your cancer profile, like the biology and etc., to give a proper recommendation. So I advise to talk to your oncologist, or you can catch me offline as well.
All right. Thank you. That's actually the last of our questions.
Okay.
Yeah, so what I'm going to do is I'm just going to share a little bit about Icon Cancer Center, where Dr. Lee is. Can you see my screen? Can everyone see my screen?
Yeah, yeah.
We can.
Okay, so Icon Cancer Center, where Dr. Lee is at, is actually a specialist oncology group with 9 specialist clinics. So you have, as you can see on the slide, you have quite a interesting team. And the QR code is there. The link to the website is there, and an email for more information is there as well if you would like to know more. One more thing about it is that they have health screening as well at their Novena Medical Clinic. So you have full medical health screening over there. And you can visit the website. You can scan the QR code right now if you want to, so that you can find out a bit more about Icon Cancer Center. And well, you can meet Dr. D there if you have a good chance to do so. All right. Before we leave for today, before we end the session for today, there are 2 things I would like to bring to everyone's attention. One is that we would appreciate everyone's feedback. So could you scan the QR code to, yeah, everything is done by QR codes nowadays. Could you scan the QR code to actually give us our feedback? That's one. And the second thing is that, as we mentioned earlier, or as I mentioned earlier, that a midday talk will be conducted at the last Wednesday of every month, which means that the next midday talk will be on the 28th of July, and it will be on insurance coverage. So if you'd like to know more about that, please join us next month. For now,
Speaking of, speaking of insurance coverage, would such procedure be covered by insurance? Do they count it under this whole cancer treatment thingy, or is it separate as having a baby?
okay, I think that question is for Dr. Lee.
Yeah, correct.
So unfortunately, like fertility treatment still cannot be covered under insurance. So that is something that, we are trying very hard to lobby for, because after all, it's due to a cancer diagnosis, right? So currently the state is that any fertility treatment cannot be covered by insurance.
Can you give a ballpark of how much it will cost for such a treatment, just so in the future when a young lady come and ask and all this thing, at least we know as a befriender in case we get asked.
Yeah. So it depends like which method, like the embryo cryopreservation and the oocyte cryopreservation. Essentially, it's almost like an IVF, right? You go through the procedure of hormonal injection, and you need to go for a day procedure for egg retrieval under sedation. So that essentially will cost close to about maybe 10-15K. However, I think it's still claimable by MediSafe. And of course, the fertility treatment in Singapore is such that, if you are like a Singaporean PR, then you get deduction of up to, if I'm not wrong, 6K if for both the father and the mother. So you get deduction for up to 6K out of like 10 to 15K. So for other options like ovarian tissue preservation, essentially is like a surgical procedure, right? That where you go for like removal of the ovaries or the ovarian tissue and then cryopreserve it. So that is a once-off surgical procedure fee. And then the other option of ovarian suppression, basically for younger women, we tend to do it monthly. So generally one injection is about a few $100s, but that there is a recurring cost to that because you need it every month, right? So that's about the ballpark figure for the different methods of fertility preservation.
Okay, thank you. It's
Mm.
expensive too. The
Yes.
government keep wanting them to have more and more babies, but yet it's getting more hoops for them to jump, even after getting diagnosis, a cancer diagnosis. Yeah.
Correct.
Right. Thank you.
Welcome.
Okay. Actually, if you don't mind, Dr. Lee, that was one last question that just came in.
Oh,
Since
sure.
we have a couple of minutes. I hope that's fine with you. Are there any post-care steps survivors need to take note of after completing their 5-year letrozole or tamoxifen meds, especially if they're looking to start a family?
Post-care, sorry?
Post-care
Medicine?
steps, or like,
Oh, okay. Essentially, I think once you completed your treatment and you're still at the age where you want to consider family planning, what's important is that, usually when you're on letrozole, it affects or any aromatase inhibitor or any endocrine treatment for that matter, it will affect your hormone profile. So, it takes time for the body to regulate itself for the cycle to start, for the hormone level to build up. So that takes time. I think the most important thing is also go easy on yourself. If you are very stressed up, it's very difficult to get things going. So keep a healthy mindset, just try to relax, do exercise, and take it easy. And if you try for a few months or even maybe up to a year, and it depends on whether time is on your side, you may then want to consider IVF early, if not late.
Okay.
Mm.
Yeah. Thank you so much, Dr. Lee.
No problem.
Yeah. Wow. I still see questions coming in actually.
Yeah, it's okay. We can.
Yeah. Okay. Yeah, there is one question is saying that are there any supplements for breast cancer ladies after completing their treatments? For example, is DHA safe?
Okay, so there are no study per se with regards to fertility or whether it affects breast cancer recurrence. But generally, I think most important, healthy diet, exercise. And if you want to do supplement, I think in moderation, because if we look at the WHO cancer survivors' well-being, the advice is take supplements in moderation. However, I will actually advise two important supplements. One is vitamin D, because a lot of us are very deficient in vitamin D. And also it depends on the type of hormone treatment that you have undergone. For instance, like tamoxifen or even your aromatase inhibitor, it does affect the bone metabolism. So I will advise vitamin D and also calcium.
Thank you. I hope that answered your question. All right, I'm just going to share screen again so whoever did not catch it earlier can get the QR code for the feedback form. Yeah, in case you didn't get it earlier. And if there are no more questions, I do believe, wait, let me see. I think there might be one. Oh, okay, no more questions, yeah. So if there are no more questions for today, first I'd like to say thank you very much, Dr. Lee, for taking out time to come and give us a talk. And
my pleasure.
And I honestly found it informative myself because I learned a couple of things as well. So yeah, thank you everyone also for joining in, and I hope you found it useful. If that is okay, yeah, if that's it for today, then I think we are done for today. So I will be sending, I think I will send this QR code to everyone again via WhatsApp, so it'll be easier for you. Yeah. All right. Thank you so much. Let me just stop. What is this? Sorry. Yeah, stay safe, everybody.
Thank you. Bye-bye.
Thank you, everyone.
Thank you.